BridgeHealth. The whole tagline we put on this thing, though, proactively managing surgery costs through patient engagement, shared decision making, and a focus on quality. A lot of what we're trying to build out at BridgeHealth fits very well with everything else we've been hearing around Cypress University and the whole intent on everything around quality, patient engagement, transparency, and pricing. So there's a lot of fit that I think we're the direction that we're going on the BridgeHealth side. I wanted to start out just with a little bit of a chronological history, though, on BridgeHealth. We certainly started from the standpoint of what you would call international medical tourism. And the whole idea that there is a way that you can get really high-quality health care in places around the world at significantly lower costs than in the U.S. It really is possible to go to Mumbai, India, and get a cardio bypass for $15,000. That in this country would cost $70,000 or $80,000. What we did at that point, though, is we negotiated deals around the country. As we started taking that out to the insured market or the self-insured market, there was a lot of interest in international medical tourism, but not a lot of people really wanted their employees to be leaving the boundaries of the United States. Is there anybody here that has any clients that have actually embraced the international medical tourism angle? What, have they shuttled people anywhere? Okay. Staying in this hemisphere then. Anybody else? That's exactly the experience that we found, that there were a couple cases where clients had a large number of possibly Hispanic employees, and they liked the idea of adding on Costa Rica, Puerto Rico, Monterrey, Mexico. But the idea of embracing an international medical tourism approach, talked about a lot, it's on 60 Minutes a lot, but are companies really doing it? We're not seeing that there is a lot of that. We do shuttle a lot of people around the world, and we've done a lot, but it's mostly the uninsured market. It's the individual who's saying, I need to get that cardio bypass, and I don't have insurance. So I'm looking for a place that I can actually do it for $15,000. So where we transitioned then, we still have the ability to do the international, and in fact, Ross, where are you at? I know, there we go. I know we're working on adding on the international wraparound on some clients that you have. And that certainly is a key part of what we can do. But where we transitioned was to this second piece that Tom mentioned. As we were working on the international medical tourism side, we started having high-quality U.S.-based providers that approached us and they said, you don't need to be sending people to Indiana or to India, send them to Indiana, you know? And the whole idea that they were willing to work with us on the same premise as the international business model, which is got to start with quality, got to be a high-quality facility, but they've got to give us a pre-negotiated case rate that shows substantial savings. And we had U.S. providers that started approaching us on that basis of building out a U.S.-based medical travel network, pre-negotiated case rates, and high quality. Where we've taken that now is into a third point that once you've identified that you can get high quality and pre-negotiated case rates, let's make sure we can get as many people into the program as possible. That's where we've expanded into identifying people early in the process, and that's the early indicators approach that Tom mentioned. So is that all making sense? I want to start then with the BridgeHealth network. So we start with the foundation, then we'll take it into the growth that we're doing into the overall management area. BridgeHealth network, the whole concept behind the network itself, it's for the type of procedures that you can plan and schedule for. So it doesn't work for an emergency situation, but a knee replacement, a valve replacement, a spinal fusion, anything that falls into the category of a planned surgery works for this program. The benefit is you've got the predictability of pre-negotiated case rates. And a case rate, of course, an all-in price. The doctor, the anesthesiologist, the hospital, it's a predictable, pre-negotiated case rate for that procedure. So the predictability of knowing upfront what it's going to cost and also knowing that that cost is going to be substantially less than what it would have been locally is one of the key advantages of this basic network idea. The third piece of this, though, is because the pre-negotiated case rates really are less than what it would be in the normal pricing mechanism, you can allow plan provisions for the employee that offer them advantages to do it. Because that's the other piece, and I know there was some mention on the whole approach of you've got to have advantages built in for the employees. There's got to be reasons why an employee is motivated to say, yeah, I want to take part in that program. I understand why it's good for my employer, but it's got to be good for me too. So because the pre-negotiated case rates offer enough savings, it's possible to provide enhanced plan provisions, waiving deductibles and co-insurance, covering travel and those other aspects that make it to the advantage of the employee. The network itself, we've got little handouts that Angela Smith is in the back, and Angela's got a lot of marketing materials that we can make available to you that talk about the network, talk about the advantages, talk about the ways of communicating this both to the employer, but to help the employer communicate it to the employee. And that's one of the areas that we're really building out our whole support mechanism to be able to have it where once you've got this network added on, let's make sure that we've got good communications so people are aware of it at the time that they might have a surgery coming up. One of the key foundations on this, of course, is on any type of a medical travel idea. It's got to start with a basic foundation of quality. We can never put any kind of program in to where we aren't offering somebody the opportunity to have it at a very high quality facility. To be in the BridgeHealth network, it's got to be in the top 25% on a company. We use care checks. You know, there's various objective rating systems that are out there. We looked at all of them. We looked at health grades. We looked at everything that was available. A company called Care Checks really does the most analytical quality rating. So we tie into Care Checks, and the providers to even be talked to by us to be in our network have to start by being in that top 25%. So they have to be, you know, very high quality for the procedures that we're bringing them into the program. And it is based on what you would think, you know, complication ratings, satisfaction surveys, clinical outcomes. When you look at from the provider standpoint, what's their motivation for partnering with BridgeHealth on this? Because obviously they're already hooked up with all the PPOs and they've got all their other arrangements in place. Why would they partner with BridgeHealth, you know, a little company that's asking them really to put together a different pricing mechanism and make it very, very competitive? Well, the reasons are they've got a lot of self-interest in why they're doing this. The first is they've got an opportunity to bring in patients from outside what their local market area would be. And we've got numerous examples. We got people we're pulling out of Alaska that are coming down to central Wisconsin for spinal fusions. And would that facility in Wisconsin ever have the opportunity to pull somebody out of Alaska separate of this program? Of course they wouldn't. They're going to pull from their local area like everybody does. So the first is an opportunity to gain access to new patients outside their local market. The second is when they give us a pre-negotiated case rate that's very attractive, part of the program is we pay them at time of surgery. So if they're doing a spinal fusion for $30,000, they've got that $30,000 in their bank at the time they're doing the surgery. That's a big advantage. That's something that is really resonating as we're talking to these providers. The third one is they're seeing this type of a program as a real good way to pilot the idea of case rates, which we all know is an important thing to be understanding and being prepared for. We've got some of the providers that have come into our arrangement that have said, this is just an ideal way to get our arms around how do we put together a coordinated case rate among all the parties that need to participate in that and work this program proactively. And then this last one, you know, they like being viewed as an innovator. What you can see up on the screen just gives an example of the case rate savings that are available through a program like this. You know, what we're comparing, we see, you know, cabbages and valve replacements, hips, knees, spines. On all of these, you know, first column shows just an average paid after PPO discount rates. We do a tremendous amount of ongoing claims analysis. We pull claims from Cypress and we pull from every one of our partners. So we're always running paid claims through our algorithms and tallying up on a paid claim basis, on average, what are these type of, you know, at DRG level, what are these procedures going for? So you can see in that first column, you know, the cabbages at $94,561 is a point-in-time average we have right now. It's always a moving number, but it's in that 90 to 110,000 range. Take a look at our case rates. A case rate of $53,000 for that procedure at a facility that is in the top 25% in terms of cardio quality. So all of a sudden you can see, well, how does this whole program work? If you can show that on average you're going to save $41,000, then you can easily jump to that point of saying, well, we got to put in some plan provisions that offer some advantages for the employee. You know, let's get some people thinking about using this thing, because not only can you put in a plan provision that says you're going to cover the travel, you're going to possibly waive deductibles and co-insurance, maybe even provide an additional stipend. Maybe you give them $1,500, maybe you give them $2,500. So we've got plan provisions that offer definite incentives and advantages for the employee to participate in this kind of a program, because what does the plan get out of it? I mean, not the savings is one, but the second thing is getting it done right the first time at a high quality facility certainly avoids future costs. Communications is a key part of this thing, and Tom and I have talked about this one, that once you can do the initial pitch of why this can be added on, that's good. But when you get into 3 and 4 and 5 months after open enrollment or after that initial discussion, everybody has forgotten about this program. And particularly from the employee standpoint, they're not listening at open enrollment anyway, and 9 months later when they're needing to have that hip replaced, they don't even know this program exists. So one of the things that we really are pumping up a lot more tightly is that the quarterly communications, and we're developing a lot more materials to where we can have it on a, let's really support a launch, and then let's have it where we can make sure on at least a quarterly basis we've got communications that are back in front of the employees. So we have a lot of the content, a lot of the materials that we can make available in a very easy way, whether it's electronic distribution or mailing or payroll stuffers. So the whole idea of communications is critical on this kind of a program, because people need to know at the time of necessity that it's available. So to summarize the parts just about the network first, the health plans really can realize substantially lower costs on major planned surgery costs. We showed the table, and we can document that a lot of different ways. We've got DRG case rates negotiated on about 150 DRGs. We have the arrangements all in place to have the full all-in episode of care on a fixed basis. So, it averages about 35% after taking into account the travel, the incentives. The way it has been playing out is about 35% savings for the plan on these surgeries. So again, that's real money, and that's a documented impact. From the plan member standpoint, to look at it from both sides, the plan can make something available, but if the employees don't use it, the incentives for the plan member, it can absolutely be pitched as it's an expansion of their access to quality facilities. Not to say there isn't quality in their local area, and certainly in a lot of the cities there is high quality, obviously. But in many rural areas, and when I mention Alaska, we got a lot of people who are pulling out of Alaska because there isn't high quality locally for them. So the access to quality is a real key part of it. The other part, though, is the plan provisions. That for an individual, and you just take your average Joe that is needing to have that hip replaced, and he finds out that with deductibles and co-insurance, his EOB is going to come back and say he owes $3,500. If he's got this other option available that says you can go to a high-quality facility, it's going to be in your region. You might live in Tulsa and you got to go to Oklahoma City, but it's going to be in your region. It's going to be a high-quality facility, and your employer has put in a plan provision that said if you choose to do that, you're not going to have any out-of-pocket costs, no deductible, no co-insurance. We're going to cover your travel costs. We're going to let your companion go along with you. And it's going to be something where you're going to be able to go to a high-quality facility and not get that scary EOB in your mailbox. So there's some real key aspects to this that, it's quality, but it is also savings. The employer has, of course, total control over what the plan amendment would be. We have a standard template that we put together, and I would say the standard most people do is they put an amendment on that says we're going to cover the travel costs, in addition to the medical costs, the pre-negotiated case rate. But we're going to cover the travel costs, which would be travel from their home location to the destination for both them and a companion. And then because the episode of care typically is a few days longer than the actual surgical time, that it's also the hotel cost. So it's the point-to-point transportation for 2 people and the hotel cost. is typically what's built in. Very similar to a transplant network. In fact, the standard plan amendment that we started with was really a transplant network plan amendment. And in concept, we've just taken the transplant idea and moved it down into the range of knees, hips, valves, bypasses, spines. I mean, major surgeries, but not at that level of a kidney transplant. Additional savings opportunity. The whole direction that we've pushed this thing, we can put a great network out there, but if we aren't catching people as early on in the process, in reality, by the time somebody has gone from their internist who has said, you need to get that back looked at, and I've got a guy for you, and he's a buddy of mine, and he's really good, and you go talk to that next guy, and he's the spine surgeon. How's he make money? Well, taking out his scalpel and working on spines. That's what he does, because he's got a kid going to Princeton, and he's got to pay for that. So you go to the spine surgeon, and now all of a sudden he's going, yep, you need to have that lumbar spinal fusion, and I've got an opening next Wednesday. Let's get it done. That train moves fast. I'm preaching to the choir on that one. I mean, that train moves fast. Without a lot of awareness and knowledge about the cost, the quality, or that third point that I think you're bringing up, the necessity. I mean, was that the only alternative? Was that the only thing that would make sense? That's where we've built out the program with a couple of key drivers behind it. The thing that I put up here was, there's been a big study by Rand Corporation that they said when you get the patient involved in the decision process earlier on, that can result in as much as a 20% reduction in costs. Well, why? Because when a patient is presented with that there are maybe a couple different routes, maybe that lumbar spinal fusion is not the only thing you should think about. Maybe there are other alternatives that are less invasive, frankly less costly, but equally as effective. I mean, there's a lot of statistics around spinal fusions that I could throw out that 80% of people who have had a spinal fusion have a second surgery within 5 years. That's scary. I mean, but what that means is that it didn't solve the issue and something else had to be done. I mean, how many people would jump at that initial spinal fusion if they knew there's an 80% chance they're going to be back on the table within 5 years? And also if they were presented with that there are alternatives that have been proven to be equally as effective and certainly better than an 80% failure rate that they should be thinking about. The second study here gets at that whole issue of necessity. Dartmouth just completed another update on their study that said as much as 30% of procedures, surgical procedures, fall into that category of unnecessary. You know, you really didn't need to have that spinal fusion, or you didn't need to have that surgical procedure. That's a scary percentage. And when you think about that, what's the best thing we can do to help control costs? It's not just a matter of steering somebody into quality with a pre-negotiated case rate, it's avoiding the unnecessary ones. You avoid one unnecessary spinal fusion and you've saved $100,000. Okay? So what we've done at BridgeHealth is we've built this into more of an integrated approach that says we have to help you get out in front of these surgery claims. And the way to get out in front of surgery claims, when Tom mentioned early indicators, one of the steps we do on that is an ongoing claims analysis where we try to catch the indicators early on of somebody who just had that initial diagnosis or somebody who just had some claim activity that's an indicator, an early indicator, of potentially a surgery down the road. So the three-part program has the early indicators. Let's identify people early on. The second part is the engagement step. And it gets at that whole issue of how do we put information in people's hands so they're at least aware of what some of the alternatives and options and risks and issues. I want to be real clear, BridgeHealth is not taking a clinical diagnosis role here. We're taking an educational role. We're saying let's provide people with the information so they can have a much more informed discussion back with their doctor. You know, what are the things they ought to be talking to their doctor about, rather than just blindly going down the path of, he's wearing the white coat, he said next Wednesday, and I'm on the table. So. The third step, though, we call surgery path, though. Certainly some of these people do need surgeries. You know, we can get out of the whole avoidance and alternative things. Some of these people need surgeries. Then let's make sure that we can get them to a quality facility. Could be one of the BridgeHealth facilities. We could also point them to one of the quality facilities in their local market. So it's the whole idea that it is good to steer people toward quality. Just to hit quickly, though, those three components, when Tom mentions that you have something in your packet where we've taken the Cypress claims and then we run it through our predictive modeling algorithms. We have very sophisticated predictive modeling that we've built. We stratify it into three categories of low, medium, and high. It's actually 20, 50, and 90% probability of requiring a surgery. And with that, it really gives a nice analysis for your individual books of business or from the standpoint of the agents, your clients' books of business, that would say, here's the frequency that's happening right now that are early indicators of future claims. So it's a whole statistical analysis step that we can do. The second step, and this is a new one that we have just started releasing in January, but we've got a number of large, really Fortune 500 companies that have bought onto this. Once we've identified somebody, let's make sure that we're providing them the information to make an informed decision. And we've got a whole web environment that goes through that premise of, if somebody has been told they need to have a knee replacement, let's make sure that they do understand what is a knee replacement. What are some of the reasons to do it? What are some of the reasons maybe to think of an alternative? What are the questions you should be asking your doctor at that point? So it's more of an educational communication step. But basically what we're doing with that with our Fortune 500 clients is we're attaching this website to their intranets so their employees can come in through their own HR gateway and then they get access to what we've put together. The third step on that falls into this whole category, though, that when somebody does actually need the surgery, let's make sure that we can provide them information about what the highest quality options that they have within their health plan. And again, this is where we can weave in two things. We can talk about the wider scope of the BridgeHealth network that's available to them. That might require travel, though. Or some people would say, I'm open to that idea and I want to hear more about it. Others will say, I really don't want to leave St. Louis. So tell me what I've got right in St. Louis. And so that's the part where we've really augmented our program to say we're hooked up with the Dartmouth company again that can really tell the quality ratings of facilities even on a local basis. So we can do a steerage step. And frankly, as we look at roles and responsibilities, because we're an independent vendor as we are, we can actually promote the concept of steerage a little more than what the PPO networks can ever do. Savings out of this kind of a program really come from two different ways then. First, we talked about the savings that would come with pre-negotiated case pricing on our whole network discussion, but this augments that. There's going to be savings that are going to come from avoiding unnecessary surgeries. The whole idea that when they get the information, doesn't run down that path of ending up on the surgical table next Wednesday. So that whole idea of let's avoid the things that really are unnecessary. Second part is, though, when people do need surgery, let's make sure they have it done. Quality really does matter, and I could throw out more statistics on that, obviously, around complication rates and readmittance rates at different hospitals. Like Tom said, you really do want to have it done at a place that does a lot of these things and does it well. And that's foundation, whether you do it in the BridgeHealth network or we just point to the ones in your local market that are the better places. So savings are going to come out a couple different ways from that. So we put the label, that's really proactive. I know that word was used a little bit earlier also on some of the other talks. This is a proactive way to help your employers get out in front of what are some of the major surgical claims that they're dealing with. Again, sort of in the idea of some of the talk about transplants was along this way. It's the whole idea that there's a whole range of major surgical procedures that we can help get out in front of, get more proactive, and make it possible to really eliminate the unnecessary, but when surgery is required, let's have it done at a quality facility, which could be a BridgeHealth facility. And that is it. Angela is in the back. She's got a one-pager brochures and things, so thanks a lot for letting us talk.